My name is Sandra Taylor. I'm a nephrologist and hypertension specialist at the Mayo Clinic in Rochester, Minnesota. My guest today is Scott Garrison, who is a family physician from the University of Alberta in Edmonton, Canada. Dr. Garrison presented his results of two trials this weekend at the European Society of Cardiology meeting, and we'll be talking to him about the results. So, first of all, Dr. Garrison, tell me a little bit about what you do and how you got into this trial.
So clinically, as you said, I have a role as a family physician. It's pretty small now. Most of the time I'm doing research and organizing family physicians to do pragmatic randomized trials, simple interventions where we can use government collected data just from usual care to answer some important questions. And this was brought about because of the MAPEC trial publication, which came out in 2010, where a Spanish group had published that there was a 61% reduction in composite of major adverse cardiovascular events if you took your blood pressure medication at bedtime instead of in the morning. That's sort of what began it. That ended up getting two groups around the world to try to independently validate those findings. One was a group out of the UK called Time, and then our group, which actually did two trials, the BedMed trial, which was in a hypertensive primary care population, and BedMed Frail, which was in a hypertensive continuing care population, so nursing homes, because the risks and benefits could differ in that population, and we knew that they were likely to be underrepresented in the main trial.
Right. Let me just pipe in. I remember when MAPAC came out, and also the Hygeia trial, I think, is by the same investigators. And it was almost a miraculous result. So, simply by taking the same medication and switching it from day to bedtime dosing, there were these extremely large benefits, survival and cardiovascular event benefits. I wasn't aware of the BedMed trials, but I had heard about Time. So I think it's very welcome in this area. We'll talk a little bit maybe about the differences between the two after you talk about your studies. So tell me about the two studies.
Yeah, so like I was saying, so one, BedMed was in a hypertensive primary care population. There were 3,300 and some people who were randomized. They were recruited largely by their family physicians, mailing letters to all of their patients who had hypertension. And they were randomly allocated to either bedtime or morning use of all amenable medications. For the most part, it was once daily medications that they'd been on that were changed. The doc could have changed twice daily medications, typically beta blockers, if they were able to. But mostly it was once daily meds that were changed. And it was the same thing in the nursing home study in BedMed Frail. In that case, it was exclusively once daily medications that changed. Both trials were parallel. It was not cluster randomized. And and in the nursing home one, randomized 776 patients. For both trials, we had a little over 300 outcomes, so 336 primary outcomes in BedMed, 320 in BedMed Frail. Sorry, primary outcome was the same for both trials. It was all-cause death or hospitalization or ED visit for MI, stroke, or for acute coronary syndrome, stroke, or heart failure.
So when you say they were randomized but not cluster randomized, this was an every other person in each practice, or how did you randomize these people?
Yeah, so it was central randomization, but it was parallel, right? So at the patient level.
Okay.
I only mentioned that it wasn't cluster because oftentimes people are assuming that At least the nursing home one was cluster randomized, but it wasn't. It was at the patient level for both trials.
Okay. Tell me about the results.
Yeah, so it didn't make any difference to cardiovascular outcomes. The hazard ratio for BedMed, the main trial, was 0.96. And it neither did it make a difference in the nursing home population for BedMed Frail. We had looked very carefully at adverse effects, both in the main trial, but again, also one of the big purposes for doing BedMed Frail was to see if risks as well as benefits were different in that population, because you were lowering what's already the lowest blood pressure of the day. So if somebody could have been susceptible to ischemic or hypotensive adverse effects, it could have been more obvious in frail older adults. So we were looking for falls and fractures. We were looking for things like decubitus ulcers, which could have been, if you had lower perfusion pressures, they could have been worse. We're looking at cognition. We measured cognition in the main trial in BedMed with a test called the short blessed test at baseline and again at 18 months. We looked for new diagnosis of dementia in the administrative claims data. We had, for both trials, we had access to administrative health data. Again, that's routinely collected in addition to what patients reported in the main trial. And family physician reporting whenever there was any discrepancy between what patient reported and what was in the administrative data.
So a couple things. There were not an increased number of ischemic events in especially the frail group, the BedMed Frail, early morning heart attacks or anything like that.
Yeah, there was no benefit, but neither was there any harms that we could detect. It seems safe to take your blood pressure meds at bedtime. It just doesn't convey any extra cardiovascular risk reduction.
So in the BedMed Frail, I was very impressed. The median age, I think, was 88 in that group. And there was really a high percentage of events. I mean, it wasn't different between the two arms, but something like 40% had events over how long was the trial?
The trial ran for about 4 years. The median follow-up was about 1.1 years.
Yeah.
But that's because the death rate is so high. And in fact, that's for BedMed Frail, the vast majority of events are deaths. About a third of those people die every year.
But they were all people who were in some kind of a nursing home, or was it also assisted living? Were there more functional folks in that group also?
Yeah, the vast majority was long-term care. There was somewhere around 15% were in more of an assisted living setting,
Okay.
but most of it was long-term care.
So how would you put your results in perspective with the other studies? For instance, time, and also going back to the Spanish registry studies.
Yeah. So, I mean, again, the initial Spanish study said 61% reduction. While we've been doing our trial and while Time was doing their trial to independently confirm, the same investigators did the Hygeia trial or published the Hygeia trial, which showed a 45% reduction. But Time, just like us 2 years ago, reported that there was neither benefit nor harm. And we agree completely with what they have found. So you have two independent groups saying it makes no difference, and then the original studies that.
Your time was larger. I think like 10,000 and in an arm or something per arm. What is BedMed and what do BedMed and BedMed Frail add? Would you say are there some added findings that kind of narrow this down or fine tune a little bit what we're seeing?
Well, I think you have another group that's done the trial completely independently, finding the same thing as Time. You're right that we're smaller, but the confidence interval for the main BedMed trial still rules out a 23% benefit. The other trials were reporting 61%, 45%. It's not like, we didn't have we found a difference and we didn't have the power to declare it. Like our hazard ratio was 0.96, times was 0.95. So, I think we support each other quite well with what we found.
What about the age? How old? The time group was younger, is that right? Than certainly the BedMed Frail.
It probably was the way they operated. They were interacting with people more electronically. Much of what we were doing was talking with people over the telephone, and there was also people who wanted email follow-up instead of by phone. But yeah, so it would have been easier to participate in our trial if you were older and frailer, even in the main community-based trial.
Well, I think these are very helpful results and reinforce, I think, your final message, which was take your medications when you remember.
Yes.
Yes.
Yeah, if you have a particular reason to take it at a particular time, go for it. But probably it's just when you're going to remember it is the most important.
So message is take your meds whenever. Yeah. Yeah. All right. Well, thank you very much.
Thank you.